This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to another collaboration between Behind the Knife and Audible Bleeding. Today we're going to be covering vascular trauma with our guest, Dr. Todd Rasmussen. Dr. Rasmussen is a colonel in the United States Air Force and professor of surgery and associate dean of research at the Uniformed Services University of Health Sciences and an attending vascular surgeon at Walter Reed National Military Medical Center. A couple weeks ago, he helped us out with the peripheral vascular trauma, and today he's going to take us through abdominal vascular trauma. Thank you, Dr. Rasmussen, for joining us again on this collaborative podcast.
You bet. Thank you for the opportunity, and congratulations to you and your team on creating such a useful information sharing venue. So I'm pleased to be with you.
We also have Adham Al-Musli on the podcast. He's a chief resident at Cornell and one of the team members of Audible Bleeding. So welcome, Adham.
Yeah, thanks. I'm excited to be here for this one.
So for the sake of time, we're going to skip the preoperative workup and description of anatomy and zones of abdominal vascular trauma. So please review this on your own. And just as a side note, we're also going to skip the management of iliac artery injuries. We covered that as part of our peripheral vascular trauma talk. It can fit into abdominal vascular trauma, but for the sake of time, we're going to just jump into true abdominal vascular trauma. So we're going to start out with a little scenario just to get our feet wet here. So Dr. Rasmussen, you have a patient with a gunshot wound to the abdomen. General surgery has already prepped them from the neck to the knees and performed a laparotomy from the xiphoid to the pubis. They packed the abdomen and temporarily have control on what they said was pulsatile bleeding from zone 1. Can you take us through how to get supraceliac control in a case like this in a trauma?
Sure. So I think for cases like this, just a couple of starter points, no case like this should proceed without, close communication with the entirety of the resuscitation team. So I think if I was coming into a case like this or participating in a case like this with our team, I would start by making sure that I was on good terms with my anesthesia colleagues, that they knew what we were facing in this situation, that they were pursuing all the key tenets of damage control resuscitation and all that means, meaning leading with blood product or whole blood resuscitation, keeping the patient warm, and all of those tenets. So I would start with that. From a technical standpoint, in these types of cases, I will almost always, you can't sew what you can't see, and I'll often really immediately assess my exposure, meaning the laparotomy. So you mentioned that laparotomy in this case was from the xiphoid to the pubis, and that's a great start. But for the approach that you have referenced and is likely to be needed in this case, I'll often reset and actually come up higher, go between the xiphoid and the costal margin, and almost begin 2 to 3 centimeters of a sternotomy. It's not a sternotomy, but it is at least coming along the side of the xiphoid and really release thoracic, the inferior costal margins of the thoracic under the diaphragm, so that you can really pull the costal margins laterally and up, so that you want to suspend your costal margins so that you're almost suspending the patient's rib cage up and away from the aorta and the abdominal contents. So I think making a good assessment of your exposure initially is really important. Hopefully, in the case that I am prepping and operating on these cases, I'll try as best I can to use a retractor such as the Omni that will allow for retractors to really be placed up underneath the costal margins. So again, you can spread those costal margins and try to lift the thoracic, almost lift the costal margins away from the abdominal contents. If you don't have an Omni, you can still make sure that you're trying to suspend that cranial aspect of your exposure. Once that's done, the other part of communicating with anesthesia is to see if they have a nasogastric tube down. Supraceliac control of in this case is almost always facilitated by having a nasogastric tube in the esophagus to allow one to palpate the esophagus in this area and then be able to get around the esophagus circumferentially and sometimes place some sort umbilical tape or sometimes a Penrose drain to allow for left-sided retraction of the esophagus away from the crus that's surrounding the aorta. The other maneuver here is really mobilizing the left lateral segment of the liver so that can either be brought cephalad or tucked, once it's mobilized, can be tucked in inferiorly and brought to the right side or the whole portion of the liver so that you've got the left lateral segment out of the way. And now at this point, one is left with the crus that's overlying the aorta. The other maneuver here sometimes, depending upon the situation, is putting the patient in a little bit of reverse Trendelenburg to let the stomach and pull that stomach inferiorly so that you create as big a window as you can with the esophagus retracted to the patient's left, the stomach kind of pulled down. Sometimes you can have a resident or an assistant put their hand on the stomach and retract it towards the pelvis, if you will. Sometimes a little bit of reverse T-Berg helps with that. And you can kind of hopefully picture this. So now you've got the ribs separated, you've really the costal margin suspended, and now you've got a window in which you can work. And at this point, now it's maneuvers dividing the skeletal muscle, which is the crus overlying the aorta. This can often be facilitated with a large right angle, and a Bovie extender. And, in this case, you can almost always see that you're dividing skeletal muscle over the aorta. If there's a pulse, hopefully there's even a weak pulse, one can feel the aorta and just divide the crus over the aorta and try to use some blunt dissection on either side to allow your palpation of the spine on either side. In these cases, I typically don't try to spend time getting circumferential control of the aorta. It's not like an elective aneurysm repair where we'll sometimes get around the entire aorta. In these cases, if you can get on either side of the aorta down to the spine, that is what is needed and is most efficient in these emergent sort of cases. So I'll stop there. If you have other questions, I mean, it's an exposure which requires a comprehensive set of things to think about. But I'll stop there for now. Do you have any questions or other comments?
So my question is, sometimes you're faced with a situation of entering a patient's abdomen. Obviously, there's a large rush of blood, and you think it may be coming somewhere in the upper aorta. Do you think it's worth taking the time to get supraceliac control in the way that you described before doing a medial visceral rotation and exposing the aorta that way? Or are there any scenarios in which you should do a medial visceral rotation first before you do that? And if so, can you take us through medial visceral rotation, when to leave the kidney down, when to take it up, sort of the pitfalls and advantages of doing each of those approaches?
Yeah, I think so. That's a great question. I think it is worth getting supraceliac control if in the scenario that you described, where the description is a zone 1 hematoma that's bleeding, and you've got some a little bit of time. Somebody may be holding pressure, but I do think it's worth getting supraceliac control if you think it's from the zone 1. Now, if it's the initial description was zone 1, and then you get in there and you look, and it actually looks to be from the spleen or from a different area, then you can readjust. But if it's truly a zone 1 hematoma that's got active bleeding, then to answer your question, I do think it's worth taking the time to get supraceliac control. The medial visceral rotation, of course, is designed to give optimal exposure to the left medial visceral rotation is designed to give optimal exposure of the paravisceral segment of the aorta. So that is, the supraceliac segment all the way down to the aortic bifurcation and really the left, primarily the left common iliac artery initially, although it can be taken across the aortic bifurcation to see the right iliac as well. In this case, that is performed through dividing the white line of Tolt along the sigmoid colon and the left colon, and establishing this plane in the retroperitoneum. And a good portion of this is steady, blunt dissection. It's facilitated with Bovie electrocautery, but it is also, there's a plane in this area that is developed with blunt dissection as well. And in the setting of trauma, almost always this dissection plane is taken from the sigmoid, the left colon, up to divide the attachments and bring the spleen and the left kidney all the way to the midline and then to the patient's right, ultimately. And I think in the setting of trauma, the kidney is almost always brought up into this and just bring the kidney up. I think it's generally easier. It's a little bit faster because you don't have to take the time to find that plane, above the left kidney and to leave it down. So in the setting of trauma, I would almost always bring that left kidney up.
I have a question. Speaking of exposure, specifically about eviscerating the bowel, I find myself, as the senior resident, sometimes appreciating actually how difficult and nuanced it is to do this. The way that I've learned to do it is kind of taking all the bowel and finding a lap pad large enough that's moist and placing some sort of clamp or something around it, and then having someone hold it outside the abdomen. But I've always found that it sort of ends up being clunky or the bowel falls out of the lap pad. Do you have any tips on how to eviscerate and control the small bowel in a situation like this?
It's a great question, and it is very difficult to describe this using in a discussion. It's one of those things where you just got to feel it. But in my experience, this is and I hope those who are listening and you can kind of picture yourself in this situation. This is really the main purview and job of the surgeon that's on the patient's right. So you can picture, you're on the patient's right, and it takes a strong and I think big, I don't necessarily mean physical, but it takes a strong and a big right hand to get that bowel up and over and to the patient's right side. You're pulling it from the left to the right. And I'm sitting here describing it, and I'm trying to extend my hand as wide as I can, and it's not a subtle move. It shouldn't be a rugged move, but it needs to be it can't be done with a gentle, it's a gentle type of thing. You've got to be strong with it. And I don't use lap pads in this situation. I'll get operative towels. So I'll ask them to get a moistened blue towel or a wet blue towel. And, basically what you do is with your left hand is you take that blue towel and you put it underneath your right hand, which has the viscera in it. And, you sort of try to get it down at the very base so that you really, that blue towel and your right fingers are coming across the aorta, because you're taking it from the patient's left to the midline, and then try to get it over to the right, and then put this big blue towel, this wide blue towel, underneath your fingers, and then, lay it out. And then hopefully, this is where I actually like in my situation, or in my preference is to use the Omni, but you're going to need a wide, retractor that's going to take the place of your right hand. That's going to now come in, on the top of that blue towel and hold all of that, and maybe a couple that hold that viscera, to the patient, to the right of the patient's midline.
That's one of those maneuvers that I feel like is very much easier said than done. And I've been humbled by it.
It's very difficult to describe.
Great. So when we talk about the left medial visceral rotation for our kind of med students out there, we're thinking that there's likely an aortic injury or a branch close off the aorta. Sometimes you'll need to do a right medial visceral rotation, though, and that's generally when you're kind of worried about generally an IVC injury. So, Dr. Rasmussen, can you just take us through a few of the nuances of a right medial visceral rotation?
Right. So this is, this obviously from the other side, and this involves dividing the white line of Tolt, starting often at the cecum and coming along the right colon, and bringing the cecum, cephalad, and the entire right colon, to the patient's left now, and then cephalad. I'm surprised most of the time in these cases, it's actually not so much a rotation to the midline and then the left as it is bringing everything up, cephalad, to almost to the patient's left costal margin, for example. And you really are almost bringing the cecum and the right colon, up onto the patient's left chest in a way. And And this is a plane that also, similar to the medial visceral rotation on the left side, this is a plane that is largely developed with blunt dissection. It's a combination. Once the peritoneum, retroperitoneum has been opened with symbovia electric cautery, then the plane should develop. And in this case, you'll see almost immediately the left iliac vein and then the vena cava. And you continue to bring the left colon up until you see the left renal vein, the right renal vein, and the kidney, and at its superior extent, this will of course expose the head of the pancreas, the duodenum, and the head of the pancreas. And similarly, the viscera in this situation, I get a wet blue towel or operating towel. I guess it can be a white towel. But I don't really like to use a lap sponge because it's too small and it doesn't quite have enough substance. And one will place that blue operative towel down along your fingers that are bringing this all of the viscera up, so that you really get it all partitioned away with a substantive operative towel. And that has to be then controlled with a large retractor so that your hands are free to actually operate.
Perfect. One thing I just want to remind some of our residents and med students out there is I would really go onto YouTube after this and just look up left and right medial visceral rotation. That'll really help solidify these points. It's one thing hearing it, but I think if you watch some videos on it, I think it'll really help bring it all together.
Yeah, I think I was going to say the same, or to obviously have an atlas, but something, because it is you got to kind of combine, I think, the words that we're talking about here with some sort of visual aid. The other thing that I would recommend and make a point is for those who have the opportunity to assist with spine exposures. So these maneuvers that we often perform as assisting our orthopedic or neurosurgical colleagues to do anterior exposure to the spine, many of these maneuvers we're talking about are performed in the spine exposure, which sometimes can be overlooked by trainees and even sometimes is, well, that's not a very good operation. You don't really get to and it's not really a vascular operation. Boy, I'll tell you, spine exposures are a great way to begin to observe or learn the tenets of rotating the viscera either to the right or to the left and exposing the retroperitoneum.
I think spine exposures and also procurements have been extremely helpful for liver and kidney. This right-sided rotation is usually the first step of any procurement, and then you're kind of seeing the entire retroperitoneum. So it's also a very good opportunity to learn some anatomy.
Great point.
We haven't discussed the infrarenal aorta yet. I think probably a slightly more straightforward approach, but can you discuss your technique for infrarenal aortic exposure and then talk about kind of coming across the renal vein, when you can ligate it, how to get it out of the way, things like that?
Right. So the most common and maybe most straightforward exposure is what we refer to as transperitoneal inframesocolic exposure of the infrarenal aorta. This here again, people who are listening and looking either at videos or in an atlas kind of recommend or recognize that the inframesocolic means that the transverse colon is reflected cephalad, and that's one of the first moves, is to really hold up the transverse colon in the patient's abdomen and drape it up, cephalad almost on the patient's costal margin. And often, I'll initially set a retractor. That also goes into a big, to me, is partitioned with a operative towel, a moistened or wet operative towel to get the transverse colon and retracted cephalad. And then the next move is to divide the ligament of Treitz. And this, to me, is always also a maneuver that's led by the surgeon on the patient's right, whether that's the primary surgeon and the attending or a resident, however you're configured. This maneuver, dividing the ligament of Treitz and getting the fourth portion of the duodenum, which is to the left of the midline, dividing that ligament of Treitz, that peritoneum, and bringing that over to the patient's right is the next move. And that begins this process of getting really the bowel. Now, in this case, the left colon remains to the patient's left, but you're bringing all bowel to the patient's right. This is not a medial visceral rotation of the entirety of the viscera. This is only bringing the duodenum, the fourth portion of the duodenum, and all of the small bowel, partitioning it to the patient's right. And this also then, again, if one can visualize this being done by the surgeon to the patient's right, on the right side of the patient, bringing that small bowel all the way across. This also takes a wide and broad and strong hand. This can't be done with, I don't know how else to say it. It's just takes a broad and strong sort of maneuver with the hand to bring this across, and then partition, get another wet blue towel. I keep saying blue, I guess it could be white, but operative towel, and put that towel over your fingers. And, as you bring the small bowel over, that's the infrarenal aorta. By positioning then retractors, one will, at the most cephalad extent of that exposure, begin to see the left renal vein at the root of the colon mesentery. And, at the caudal most portion of this, you'll see the aortic bifurcation. And, that's sort of the extent of this. The left renal vein can be ligated if it facilitates aortic control. Obviously, if one is going to ligate the left renal vein, it's optimal to leave the branches of the left renal vein, so the gonadal, the lumbar vein, which also often will drain the left kidney, and then the gonadal. So if those are left intact, dividing that left renal vein can usually be accomplished without causing significant detriment to the left kidney. I will say that dividing the left renal vein is easier said than done. I mean, it is it's a thin-walled structure, which of course can bleed significantly itself. So, these are all sort of decisions that have to be made depending upon what injury you're dealing with and the extent of your exposure.
I think one question I forgot to ask you earlier was, I think infrarenally, the aorta is a little bit easier to get around completely and put, an umbilical tape or a vessel loop around. But like you mentioned earlier, in the supraceliac area, that's a lot harder to do. And sometimes the goal is not to always do that. But you have tips on how to do that? Because again, I've been humbled by that in a procurement one time when the attending allowed me to try and get around it. And I tried bluntly with my fingers to get around the posterior aorta and had a lot of trouble. So do you have any tips about that?
Well, I think this just takes, experience and time. I mean, in my own mind, as I see this, this is a combination of sort of a little bit of Metzenbaum scissors, a little bit of kind of pushing, because what you're trying to do is to free the aorta from the connective tissue around it to get back to the spine. Sometimes, actually, almost always, I'll use a metallic pediatric Yankauer. That is sort of one of the suction or dissection tools of choice is this Yankauer, which is small in profile. It's got a blunt tip. It will, it is a suction device, and so that's useful. And, kind of this combination of pushing a little bit of Metz here and there, Metzenbaum scissors, and a little bit of feeling with your finger till you can get that connective tissue around the aorta freed. And then, one can begin to use a right angle, a big right angle, and try to get underneath it. Obviously, what you're looking for here in part is lumbar. You're looking for the lumbar vessels, which, those are the things you need to leave behind, or at least by, as we tell our residents, find the outside before you find the inside. If you can find the outside before you find the inside of a lumbar, then you can clip it. Another, I think, very useful tool in this situation is having large WEC clips, because it's very difficult to pass, a silk to ligate a lumbar. And in these situations, a lot of times, you need those large WEC, medium to large WEC clips to help, get on either side of a lumbar artery or vein.
One quick point back to the renal vein, I kind of picked this up just this past week, is you can really get a lot of mobilization on the renal vein just by ligating some of the smaller branches out distally on it, not even the gonadal, but sometimes the adrenal vein and a few of those veins. And you can really get 5 centimeters of mobilization of that renal vein, which should give you enough distance to clamp. But now we're going to go into each vessel off the aorta. And I know this isn't exactly what you're going to see in a trauma. You don't have isolated celiac artery injury or isolated SMA injury, but just for the sake of learning, we're going to talk through each vessel and talk about the options of exposing it and then repairing it. So starting proximally, Dr. Rasmussen, can you discuss what the best ways to see the celiac artery are and any options for repairing it?
Yeah. So the celiac artery, I guess the origin of the celiac artery can be seen either through the lesser sac. This is again through an anterior approach through the lesser sac, and this would likely be very similar to the exposure we talked about with supraceliac aortic exposure, where the sac is retracted, caudally down towards the pelvis. And, that opening the lesser sac and pulling the stomach down and sort of getting the pancreas to come down, that will expose then the origin of the first centimeter or two of the celiac artery. If the proximal segment of the celiac artery is injured and bleeding, then the repair options, I think, into the category of any vascular, major vascular injury. If it can be repaired primarily, then, using a 4-0 or 5-0 proline suture, if it has a grazing wound and repairing it primarily can be done, then that's one option. If it's a large, celiac artery injury that cannot be repaired primarily and there's destruction of the wall, oftentimes an individual's in really a damage control situation there. And repair is not so much your first line of thought. You're really in that situation trying to just control bleeding and save the patient's life. And so in those cases, controlling the celiac artery and even consider, ligating it may be necessary, as a damage control maneuver, at least initially. The other way to see the origin of the celiac artery is through a left medial visceral rotation. So the maneuver we described before will expose the paravisceral segment of the aorta to include the first centimeter or two of the celiac artery.
So any keys to identifying the common hepatic artery, and again, thoughts on ligation strategies and repair strategies?
Right. So I think the common hepatic, that will not be able to be visualized through the left medial visceral rotation. The common hepatic and getting out into the segments there of the major branches of the celiac, one will need then in that case to be coming from a transperitoneal, anterior approach to the lesser sac. And, identifying the common hepatic, requires sort of a recognition of where the celiac artery is. You're in the lesser sac. The stomach really has to be pulled inferiorly. This is, again, if you find yourself operating in this space, the costal margins, as I said to begin, really have to be flared and almost suspended up so that you've really opened this. Sometimes reverse Trendelenburg is useful. Getting a resident or a med student's hand to pull the stomach down and open up that space, that will then should expose then the second and third segments of the celiac and its major branches to include the common hepatic artery.
Great. And so as far as ligating the common hepatic artery, how does the GDA play into this? By that, I mean the gastroduodenal artery.
Well, the GDA is I guess is most commonly the case, as you know, and listeners know, is really one of the first or the first branch of the common hepatic artery and really defines the junction between the common hepatic and proper hepatic arteries. And I think, ideally, the common hepatic should not, ideally, you don't want to ligate any of these arteries, right? So I think that we start with that premise to say, geez, if we can get a repair done, that's going to be option A, whether that's the common hepatic, proper hepatic, or GDA. Just like any artery in the body, ligating it may be required as a damage control maneuver, just to control hemorrhage, let the patient recover a little bit, talk to anesthesia, and sort of see how things are going, make an assessment of the region distal to where you've ligated. So this is just a basic tenet of ligating any artery in a damage control situation. We recognize no matter which artery we're ligating, the consequences of that ligation are, we need to assess those consequences and then address them if we're able, if the patient's able to move to the next step. So obviously ligating the common hepatic distal to the GDA is likely to render, a significant portion of the duodenum, the pancreas, and then the liver ischemic. And so, if the ligation can occur proximal, if the injury is proximal to the GDA, then that would and perfusion can be maintained into the GDA, then that's preferable. But if I was in one of these situations, or when I am, and we find ourselves having to ligate it, or we ligated it, we didn't quite know because we didn't, but we had to, it was bleeding and there was a clip, and we had to just a damage control maneuver, and now GDA or the common hepatic or the proper hepatic's ligated. Now what I usually do is we'll talk to anesthesia, we'll get the patient as resuscitated as we can, we'll get out the Doppler, we'll make an assessment, because, depending upon patients can tolerate, depending upon their resuscitation status, collaterals, where your ligation is, they may be able to tolerate having any one of those vessels ligated. If, on the other hand, you got your Doppler and you get the patient resuscitated as possible and there's clear ischemia, then you're going to be faced with the decision as to whether or not we need to reconstruct this ligated vessel, shunt it, or maybe a situation where you have to deal with the metabolic consequences and leave it ligated. There's not one answer, I think there's not one answer that applies to all situations. I think it's learning and adhering to the principles of damage control resuscitation and damage control surgery.
Perfect. Thank you. Okay, and now let's dive into the SMA. And this is, very close in proximity to the celiac artery, so many of the options to visualize it will be the same, but there's some unique differences with its relationship with the pancreas. So briefly, Dr. Rasmussen, what are our options to see the SMA, and do we kind of think of the SMA kind of in portions a little differently than some other vessels?
Definitely. So the SMA, the best way really to see the first centimeter to the SMA superior mesenteric artery is through the left medial visceral rotation, which will show the entire paravisceral segment of the aorta, including the first centimeter to of the superior mesenteric artery. If more exposure needs to be, if one is trying to expose the more distal segments of the SFA, then one probably have to go back to the anterior approach, not the left medial visceral rotation, and go through the anterior approach. And in this case, then the superior mesenteric artery is, of course, closely related to the head of the pancreas. And so in this situation, the head of the pancreas needs to be, divided, or, the SMA is closely adherent to the head of the pancreas in this case. Distal, the segment of the superior mesenteric artery distal to the pancreas, is often now best seen in an inframesocolic approach. And this is as the superior mesenteric artery exits its sort of second segment and its relation with the pancreas and comes out into the root of the mesentery and into the small bowel. This is where, for example, one would lift the transverse colon cephalad, as we described before, and then retract the small bowel to the patient's right and see the root of the SMA below and inferior to the transverse colon. So yes, there are these distinct segments of the superior mesenteric artery exposed each of those segments has a little bit of a different anatomic approach, and each of those segments has, I think, considerations that are important that relate to surrounding structures. Whether that's obviously the pancreas, the root of the transverse colon, and such.
Thank you for taking us through those complicated anatomy of the SMA as it kind of traverses the abdomen. And all these vessels, obviously, primary repair is kind of our first option if possible. And then many times you may need an interposition graft. Just, I know this is a question that is very case dependent, but is there a portion of the SMA that you can ligate, or is the SMA just a no ligation zone throughout?
Well, that's a great question. And I think similar to other large axial vessels or arteries, ligating the more distal segments is just going to be better tolerated than ligating the proximal segment. So, I would not say it's a no ligation zone throughout its entirety, but I do think, that if possible, efforts should be undertaken to maintain flow through the SMA through its entirety. And, repairing the SMA, it depends upon the injury. If it is a small grazing wound, then perhaps a primary repair can be undertaken with a 4-0 or a 5-0 Prolene suture. If it's a more substantial wound and one can get it controlled and isolate it, then repair can be undertaken with a patch angioplasty or even an interposition graft. That's pretty rare in trauma because those wounds are just so mortal. It's very difficult. Patients who have those sorts of axial injuries at the proximal portions of these mesenteric vessels typically don't survive. And so, it's very difficult. I can't think of a time when I've necessarily been repairing for trauma the proximal segment or two of the SMA. It's a little bit different for an elective tumor resection, atherosclerotic occlusive disease and such. But for trauma, it's pretty uncommon to be doing extensive repair of these SMA segments. I don't know what your experience is or thoughts are on that.
I certainly have had zero experience repairing SMA injuries, but I know that, like you said, interposition grafting is probably more theoretical than realistic in a situation like this. But can you talk about the technique for it? Maybe it may be useful for other types of situations, but what material you're using, where you're bringing the graft from, and how you tunnel it.
I was just going to say, I think you guys are exactly right, and Adam and I have both experienced this. Many times we're not seeing traumas with these injuries, but many times we're getting called by the surgical oncologist with a kind of cancer injury to these vessels. And so I think when we're discussing SMA, we can kind of keep it in the perspective of how do we replace it if we need to in the situation where they need to do some larger section. So with that in mind, Dr. Rasmussen, can you tell us how you would bypass it?
Yeah, so I think in these cases, and as I said, in a rare situation in the setting of trauma, if you've or able to establish proximal and distal control and side branch control of this segment, and then your options for reconstructing it with an intraposition graft, would include using a prosthetic like PTFE or Dacron, or an autologous tissue like vein. And here it depends. It depends on how prepared you are with the patient. For example, as a patient prepped, where one could harvest either the very proximal segment of greater saphenous vein or a segment of deep femoral vein, which may actually have a better size match to the proximal portions of the SMA. And if that's the case, if there's enteric contamination, either from a tumor resection or from an injury, then it is preferable, of course, to use autologous conduits such as deep femoral vein, a small segment of deep femoral vein. Or if the saphenous at its proximal extent is large enough, one can use that. If that's not possible, for example, the leg isn't prepped or the expertise that is not available to harvest the deep vein, then I think using a small segment of rifampin-soaked Dacron graft would be probably what I would use. And, you get some rifampin from the pharmacy, you get probably a 6 or 8 millimeter diameter segment of Dacron, and that's your interposition graft. As far as tunneling it, that and how to route it, that sort of depends upon the injury. Obviously, the proximal most segments of the SMA are, right underneath the pancreas. If this involves, for example, a Whipple procedure where the head of the pancreas has got to come out, and with that, a proximal portion of the SMA, then that's probably going to require a 6 or 8 millimeter diameter interposition graft, to replace that. And if it's more distal in the SMA, and now it's, in the inframesocolic, the transverse colon is up, and in the injury, or the segment is, for example, below the transverse colon, then that's going to be, 3 or 4 millimeters. And it may be there that vein, saphenous vein would work. Or in some of those cases, a patch angioplasty using vein is actually easier and better than trying to do an interposition graft. Is to sort of debride the injury and then do a patch angioplasty using a segment of saphenous vein.
All right, one follow-up question. In these situations with SMA injuries, say you repair it and the bowel doesn't look infarcted or threatened at the time, do you think it's mandatory to leave these patients open and do a second look even if everything looks fine on the first time, or do you think you can kind of take it on a case-by-case basis?
Yeah, I think you're getting at an important point here, which is one we've emphasized throughout our discussion, is that none of these procedures, these techniques that we're describing, take place in isolation. Right? They have to be in conjunction with anesthesia and an assessment of the patient's physiology and the whole team, including the intensive care unit team, et cetera. So. It's a really good point. My own preference in these situations is to leave the abdomen open with a temporary abdominal closure of some sort, and plan a look, 24 to 36 hours later. I really recommend that. I think we know that the morbidity of that approach is very low. And I suspect, I think it probably provides not just reassurance, but probably some real advantages in case the perfusion actually is not adequate and the patient becomes acidemic and the bowel is compromised, subsequent to your initial departure from the OR.
Great. And just to breeze through the inferior mesenteric artery, would you agree that you can generally ligate this with impunity if it's damaged in a trauma situation?
I think I never say ligate with impunity, but because there's always situations where, I think it has to be thoughtful ligation. And in this case, yes, I think the majority of times the inferior mesenteric artery can be ligated. I think the thoughtful approach here is to make an assessment to the patency of the iliac vessels, and specifically the internal iliac vessels. I think if what we're describing, which is ligation of the inferior mesenteric artery, one can be more assured that that's going to be tolerated if both internal iliac arteries are patent, for example. If the SMA is patent, the celiac is patent, then ligating the inferior mesenteric artery is almost always tolerated. If it's an aged person who's got occluded internal iliacs, or they've got atherosclerotic disease and their mesenterics are not good, then I think you have to be a little worried about ligating the IMA in some cases.
Right. And just for residents that'll be rounding, I think we generally discuss when talking about the IMA and open aorta situations, if it's occluded or it's pulsatile, then we feel comfortable ligating it. It's when it has that kind of slight dribble back that we may consider reimplanting it, just to kind of prepare you for your rounds. Dr. Rasmussen, we're going to jump into the last vessel of branches of the aorta, but not an easy one to discuss either. We're going to discuss the renal arteries. And, I know it differs kind of whether it's proximal or distal very much as far as your exposure, but how do you think of the renal arteries in your management of them in traumatic situations?
Yeah, I think that what I'm thinking about in that question is similar to these other vessels and hopefully it's helpful as a broad principle and approach. We started this discussion talking about exposure and making sure communicating with anesthesia and, having the right suction devices and retracting devices and headlights, these broad concepts to make sure that you've thought about going into these cases. I think when it comes to the renal arteries, like all these vessels, it's useful to think, well, I'm either in a fairly elective situation, meaning I've got things under control. For the most part, the patient's physiology is solid. There's whatever bleeding there is controlled, and I've got a reasonable exposure. In contrast to, I am in a uncontrolled situation, and there's the patient's in a really bad situation. The bleeding's not controlled. I don't know where the bleeding's coming from, et cetera. And I think because it helps one to have a mindset about whether I'm pursuing damage control surgery. Am I going to have to, how much am I going to work to maintain patency of this vessel? Or am I going to be more tolerant of ligating it and just as a damage control maneuver and having to deal with the consequences, but recognizing I need to do it to save the patient's life? So the renal arteries are like that, I think, because it is similar to the SMA. It is pretty unlikely in the setting of trauma to be reconstructing a renal artery. I think it's pretty rare. In trauma, the kidney, the renal artery is either not injured, and there's hematoma, but it's from the parenchyma of the kidney or surrounding vessels, or the renal artery is injured and thrombosed, and certainly if it's injured and thrombosed, by the time an individual gets to it, it's probably too late. The ischemic time, warm ischemic time to the kidney has been too great, and there's not going to be value of trying to reconstruct it in the setting of trauma. And so if it happens to be an in-between, you say, well, let's say that actually it is one of these cases where, explore the zone 2 hematoma and it is coming from a main renal artery, then, and there's flow in it, but it's bleeding, then I think the principles that we have described, such as either primary repair, 4-5-0, potentially probably in this case, maybe a 6-0 monofilament suture, such as Proline, would be useful. If that appears to compromise the lumen, then either a patch angioplasty of that artery or, a bypass. But again, that is extremely rare in the setting of trauma. If it's going to require more than a primary repair, it's, I think in my experience, equally likely that, you're going to be ligating that vessel for damage control, but it's pretty rare to be doing a complex renal artery repair in the setting of trauma. Similar to the proximal SMA injuries, for example, they're just pretty rare.
Can you talk to us about what your approach is to dealing with renal hematomas, whether they're penetrating or blunt? I know the old adage of every penetrating renal hematoma should be explored and blunt ones should not be explored unless they're expanding. May not be true, but can you kind of walk us through how you approach this?
Right. So, zone 2, this would be, zone 1 or the central abdominal hematomas. And, the rules that you're alluding to are that, almost all or all zone 1 hematomas should be explored. Zone 2 hematomas, which are the kidneys in the lateral gutters, basically, the general rule is that if it's a expanding hematoma, regardless if the mechanism is blunt or penetrating, then those hematomas should be explored in zone 2. The general rule goes, as most of your listeners know, if it's a blunt injury and the zone 2 hematoma is not expanding, then that does not need to be explored. In contrast, if it's a zone 2 hematoma from a penetrating mechanism, then most of the time those then need to be explored, even if the hematoma is stable. Those are the general rules that we use to guide our approach to zone 2 retroperitoneal hematomas. So I use those. I think those are pretty good. I think there are times when a blunt, one finds themselves in the belly because there was a hemoperitoneum from another injury, and there is a blunt mechanism, and there's a zone 2 hematoma. I have explored those in the past, and I think that I don't think those guidelines are meant to be dictums that can never be adjusted for an individual case.
So one question, I know a lot of times, many of these cases, we don't already have the laparotomy performed. They're in the trauma bay, they get a CT scan, and they call and say there's an intimal flap, there's a fistula, maybe a pseudoaneurysm in the renal artery. Any kind of general principles for some of these sort of incidental findings?
So what you described there is the most, obviously, I guess, the most common scenario in which it's a CT finding, right in or just after the resuscitation room of a main renal artery injury, branch renal artery injury, or maybe, a parenchymal injury to the kidney. And in those cases, I think let's say it's the intimal flap that you described, if the intimal flap is either not limiting, and there's perfusion in the kidney on that CT scan, for example, and it does not appear to be flow limiting, then that can be observed. Some of those, like other blunt arterial injuries, some of those will heal. If it is amenable to an endovascular placement of a bare metal stent, that can be used in some institutions to tack down or stabilize that dissection. And that would be if you really feel like it is a flow limiting, more than 50% stenosis caused by that intimal flap. The more distal branch artery injuries can often also be managed with endovascular techniques such as coil embolization, replacement of an endovascular occlusive, hemostatic coil or other device. And I think coil embolizing or treating those depends upon, how the patient is doing, how much blood they're requiring, how large the hematoma is, and then what their hemodynamics are. But I think for those reasons, what we described 5 or 10 minutes ago, having to fix these renal artery injuries in the OR is pretty uncommon because they've either been diagnosed and managed based off CT with or without endovascular technologies. And oftentimes the management of a renal artery injury, if you're in the OR, exploring and expanding, hematoma in one of the zone 2s is going to be nephrectomy, because it's that major injury in which there's not the indication for repair.
I want to thank you very, very much for taking a complex topic that's sort of convoluted and breaking it down from technical steps to algorithms for exposure to how to repair. I think this was overall an excellent episode. What we haven't touched on is endovascular management of trauma, which we'll save for another episode. But thank you so much for a great discussion, Dr. Rasmussen.
Well, I applaud you for tackling the topic is unruly, both in the anatomy, the anatomic exposure, operative exposure, and then the seemingly endless number of scenarios that can be considered for either observation, repair, or damage control ligation. I mean, it's a complex topic. I would commend you for tackling it, and I hope that our discussion is useful for you and your listeners.
Definitely. I think this gives people the groundwork to really make some safe decisions. One thing I want to mention to our listeners, if you click on our show notes or you go to audiblebleeding.com, we're going to have links to different YouTube videos that will have breakdowns of many of these exposures. So you can listen to this and then go watch it later to really reinforce it. So thank you, Dr. Rasmussen, again, for an extremely complex episode that you're breaking down onto a podcast.
Thank you for listening to Audible Bleeding. This is part 2 of 6 of our vascular trauma series with Dr. Rasmussen. Be sure to tune in to hear the rest of the series.